Good morning to all. I welcome you all to this GAN program on implantable artificial kidney for future kidney on chip. So with us we have expert from Russia, that is Professor Boris. So I welcome Professor Boris. Professor Boris has many years of experience in the area of this kidney and heart, and they are doing hardcore research on biomedical engineering. So with this, I welcome Professor Boris to this program, and we hope that from his talk we can help a lot and learn from his expertise. So I welcome Professor Boris to this program. Thank you.
Good morning, everyone, dear colleagues. Just allow me to shortly introduce myself in the matter of this course. My name is Boris Putre. I'm a senior engineer of biomedical of things. Good morning, everyone, dear colleagues. Allow me to introduce myself. My name is Boris Putre. I'm a senior engineer of the Institute of Biomedical Systems of National Research University of Electronic Technology. And tonight I would like to start our course related to implantable kidney technology on chip. It's basically a technology that is supposed to assist people with chronic kidney failure, and it's supposed to improve the social mobility of patients who suffer from chronic kidney failure. And just to emphasize my field of expertise, I was working on wearable artificial kidney, and to be more specific, I was working on dialysis regeneration unit. So, as you all know, the kidney is basically a blood filtering organ that provides the homeostasis of the human blood and human organism. It actually provides the continuous removal of urinic toxins and excessive water from human organism, but it's not the only functions of kidney. There is endocrine function, there is the hemostasis function, and kidney actually provides a reabsorption of a good chunk of water and nutrients that people consume on a daily basis. So in the matter of the first lecture, we'll just introduce the main idea behind the blood filtration in a native kidney, just for common introduction, that the kidney is basically a very sophisticated organ that is not very easy to be replaced by any artificial system. And one of the main trends that actually exists nowadays is the attempt to develop the wearable and implantable systems that will provide the continuous blood filtration for patients who suffer from kidney failure. And it will not just improve the quality of renal replacement therapy, but it will also improve the social mobility of the patient, because he will not be forced to stay a huge chunk of time in the hemodialysis system, or restricted by the necessity to perform peritoneal dialysis in a dialysis center or at home. So let me start from the general introduction on nature of kidney and nephron functions, and the basically definition of what chronic kidney failure is. How do I change slides? There is a short introduction of the system theory, like every complicated system that we deal with, the human organism can be considered a system on itself, and one of the main properties is the integrity of our system. So we cannot reduce the the organism as the biological system to just the sum of the properties of the parts of our organism. It's a highly organized system, so there's a hierarchy between different systems, and they are interconnected between each other in a very complex manner. So basically, even if we talk about the blood filtration in human kidney, and if we talk about, for instance, the water reabsorption, there is interconnection between the nerve system and the endocrine system and the kidney function. Because, for instance, when we drink water on a daily basis, for instance, if we drink the excessive amount of water, then the kidney, as the blood filtration organ, is supposed to remove this excessive fluid from the organism to make sure that this blood will not accumulate in tissues around the organism. But for instance, if we have a situation when a human does not have an opportunity to drink enough water and he suffers from dehydration, then vasopressin, a hormone that generates in hypothalamus, actually provides the reabsorption of water in collecting duct, thus returning water back to the organism. So that's just an illustration that even if we talk about the functionality of the human kidney, it's still interconnected with other parts of the human organism as the system. And of course, if we talk about relationship, we do not exist in vacuum. We interact with the environment, and everyday food consumption actually affects the human organism in terms of metabolism. So basically, one of the main functions that kidney are supposed to maintain is the homeostasis of the organism. Next slide, please. So yeah, homeostasis is a self-regulating process that provides biological systems an opportunity to maintain the stability while adjusting the conditions that are optimal for the survival. And here is the short illustration on the pH, the acid level of the acid value of blood. It's an illustration that is given for the breathing process. So if we talk about such parameters as pH, it's not just regulated by the lung system, it's regulated by kidneys as well, by other systems that actually affect the pH of the human blood. But here is just a small illustration how it works during the breathing. So if there is acidosis, that means that the parameter pH decreases. It stimulates brain and arterial receptors that actually increase the respiration rate and the heart beating rate, and in return it decreases the concentration of CO2 in blood and CO3, which in return increase the pH of blood, and vice versa. It's not just we need to maintain so if we have this situation and the pH of blood increases, then it again stimulates the brain and arterial receptors, which decreases the heart beating and respiration rate, which increases the concentration of CO2, and it in return decreases the pH level. So the normal pH of blood, if I recall correctly, will be 7.33. So in terms of homeostasis, we're actually talking about the dynamic stability of this parameter. So we can expect that at some values this parameter will change. But in regards of human organism, the homeostasis is the process or a natural phenomena that actually leads to maintaining the dynamic stability of this parameter to make sure that it will not exceed any critical level of this specific parameter. And it basically goes for many values, such as the concentration of sodium, for instance, the concentration of any iron in blood, it goes for the concentration of glucose, etc., and so on. So homeostasis is a very complicated phenomenon, and in terms of kidney function, what I want to tell you is that kidney is basically one of the main organs of the homeostasis in our organism. It's basically an organ that provides the blood filtration, not just blood filtration, but it affects blood in many manners, like the calcium metabolism by producing the calciusterol, the hormone that actually provides the metabolism of calcium. It actually participates in a blood formation by stimulating the secretion of renin and other hormones that stimulate the blood formation. So in that regard, human kidney is a very essential organ that provides the stability of blood composition in terms of the iron composition, in terms of pH, in terms of the nutrient concentration, in terms of the metabolites concentration, in terms of the water level in the human body, and basically it's not just a blood filtering organ. And in that regard, it's a very complicated organ that performs a lot of function without our organism. Yeah, next slide, please. Yeah, that's just a brief, here, we have the link is there. Yeah, that's just a brief explanation of kidney as essential organ of blood homeostasis. So basically, kidney is supplied by renal arteries. It's a bare organ that is positioned on the both sides from the spine, and it consists of the cortex part, the medulla part, where actually nephrons as the structural units are positioned, and it's supplied by renal artery, which supplies both cortex and medulla, and the filtered blood goes from the venal veins, and the filtered, like the main product of the blood filtration, urine, actually goes to the collecting ducts that goes to ureter. So this is basically where the main blood filtration goes. And just like I said, kidney cannot be reduced just to blood filtration, but blood filtration is one of the main functions of kidney because it provides the removal of excessive water and removal of urinic metabolites that actually generate during our daily life. So here you can see the main functions that we discussed earlier. It's the blood filtration, it's the secretion of the metabolites and excessive water that the kidneys filter. It's endocrine function that participates in many levels in the human organism daily life. It's hemostasis and so on. But we basically need to address how exactly kidneys thanks. Yeah. Yeah. So basically, when we talk about the blood filtration, we need to address what is the structural unit of the kidney that provides the blood filtration. Well, the structural unit of human kidney and any kidney of mammal is nephron. It's basically a very sophisticated structure that provides many stages of blood filtration and water reabsorption and nutrient reabsorption. And basically, the one human kidney is populated with more than 1 million of these nephrons, which provide the continuous blood filtration. And that's essential to remember in comparison if we talk about the conventional dialysis methods like hemodialysis and peritoneal dialysis. Natural kidney is an organ that provides a continuous blood filtration, continuous reabsorption, and continuous secretion. So this is the part that is quite difficult to implement in terms of artificial kidneys if we talk about kidney chronic failure. But here we can see the main structure. So the blood filtration starts with glomerular capillaries and Bowman space. That's basically the part of the nephron where the initial filtration starts, if we just foreshadow the main. Here, just a small foreshadowing of the main functions of the nephron. That's a glomerular filtration that takes place in Bowman space, a tubular reabsorption. I will explain later why exactly the kidney requires to perform that function. It's tubular secretion and finally it's excretion. So coming back to this slide. The initial filtration starts in Bowman space, and the reabsorption takes place in proximal convoluted tube that goes to proximal straight tubule that ends up in the loop Henle that actually consists the descending Henle loop and ascending Henle loop. Then it goes to the macula densa, the distal convoluted tube, and it goes to the collecting tube where the urine excretion goes. So the reabsorption takes place in this part, the proximal convoluted tubule, the straight tubule, and Henle loop, and usually the Bowman space is positioned in the cortex of the kidney, while the Henle loop goes to the outer medulla. Some longer Henle loops go to the inner medulla. And if we remember the decomposition of the main stages of blood filtration, the initial filtrate, the primal urine, is formed in the Bowman capsule, and perhaps I can write down before we are. For sake of simplicity, I will just skip the explanation of why this equation looks exactly like that. We will consider talking about this particular topic in the first tutorial where we address the topic of modeling of the human functions. So we have hydraulic permeability multiplied by hydrostatic pressure of human blood. Let's just mark it like that, minus the hydrostatic pressure that exists within the Bowman space. Is the hydrostatic pressure of the primal urine minus the oncotic pressure of protein in blood. I will try to explain later why exactly we actually describe this particular ultrafiltration flow like this, because if you remember, there is not just the hydrostatic pressure, but there is there is also the osmotic pressure that is created by small solids like urine, sodium, etc., glucose, and there is the oncotic pressure that we should expect in the Bowman space liquid. But for the sake of simplicity, we will just present it like that. we will discuss that in the first approximation we assume that protein does not penetrate the membrane of the Bowman space capsule, and it does not go to the primal urine. That's why we exclude the parameter of oncotic protein pressure in Bowman space. Yeah, I need to actually fix myself because we consider that blood. And considering the hypermobility of the membrane, the osmolality of both blood and primal urine is nearly the same. That means that the difference between osmotic pressure in blood and Bowman space is basically equals zero in that particular approximation. And that's basically the formula that provides us the opportunity to calculate the glomerular filtration rate for a specific nephron structure. Yeah, let's go to the Bowman space. Yeah, that's basically the first part of the human nephron where the blood filtration starts. It's basically the structure where the primal urine is formed. And basically we have here the glomerular capillaries that approach the Bowman capsule through the afferent arteriole. And here with the blood system, the heart that is a pump unit, it creates the enough of hydrostatic pressure, or blood hydrostatic pressure to initiate the ultrafiltration flow through the capsule, the Bowman capsule membrane. And the filtered blood then goes to efferent nephron that goes to the vasorector. Here in relationship to the proximal convoluted tubule and proximal straight tubule and the loop, some amount of substrates and waters goes back to pertubular capillaries, and the filtered blood then goes to renal vein. So why exactly so the first question, why do we need other difficult nephron structures for a proper blood filtration? The problem is if we actually had only the primal urine filtration in the Bowman space, and considering that the healthy human kidney actually has the glomerular filtration rate about 120 milliliters per minute, we can estimate that in that regard we would just filter out all water and nutrients in a matter of 30 minutes or even less. So basically it would be a very dangerous and a condition where we would not be able to exist. So in our regard, in order to maintain the water volume in human organism and remain the amount of the healthy amount of nutrients that could be filtered out if there was no reabsorption here, the nephron has a very specific structure that provides the further reabsorption of water and further reabsorption of nutrients. So Bowman space capsule is a very essential part of nephron, but it's not the only part that actually allows kidneys to properly filtrate blood without any excessive water losses. So we're talking next about the Henle loop, and which actually goes from the straight proximal tubule. And in order to find out why we actually have such an, why kidney actually provides the reabsorption of water and reabsorption of nutrients, we have to address the Henle loop and the counter-transport phenomenon that takes place in a human kidney. So basically, Henle loop is a two parallel tubules that can be divided in the descending Henle loop, descending branch of Henle loop and ascending branch. And what they actually do, the main function of Henle loop is basically a reabsorption of water that takes place in a descending branch of the Henle loop, and descending limb, I'm sorry. in the descending limb. And in ascending limb, we actually absorb the reabsorption of nutrients that go back to the interstellar space of the human kidney, and those nutrients and water are reabsorbed back by the ascending loop of the vasa recta. So basically, the main, let's say, the main phenomena that takes place here is the osmosis that takes place in descending loop, in descending limb. I'm sorry, and it becomes possible because there is a difference of osmolality between the urine and the interstellar space. And osmolality is basically a cumulative concentration of all substrates that are dissolved in water or any other solid. And what actually happens here is that we have the osmolar primal urine that is very close to osmolality of human blood, and it descends in the outer medulla where the osmolality of the intercellular space increases in comparison with the primal urine osmolality, and it forces the process of osmosis. That means that if the osmolality here is lower than in the outer medulla and inner medulla, the water will diffuse from it will go from the descending limb to the intercellular space, and it will go until the concentration, the osmolality parameters of both primal urine and intercellular liquid become the same. And when we go down the descending limb, we actually observe that the osmolality of intercellular space is always higher than osmolality of primal urine. So basically, in descending limb, we observe the phenomenon when primal urine becomes more concentrated, and the main purpose of descending loop in that regard is basically water reabsorption. So we can assume that the descending loop is permeable for water, but impenetrable for any substrates. So this descending loop returns only water. In terms of the ascending loop, it goes from to the thick ascending loop that is impermeable for water, but permeable for the nutrient diffusion. So basically what happens here is the opposite problem. So we have a very concentrated urine that goes across the ascending loop, and the concentration of the urine, the osmolality of urine is greater than the osmolality of the intercellular space. And here we have the opposite situation. This limb is not permeable for water, but it's permeable for solutes like sodium, sodium chlorine, glucose, etc. So basically what happens here is due to difference of the solute concentration. The concentration of the solutes is higher than here. We expect the diffusion of the solutes back to intercellular space of human kidney. And we, in return, observe that the primal that urine becomes more diluted in comparison with the lower level of the handed loop. So basically, the main purpose of the ascending loop, not just the way that it returns the solids back to the intercellular system, but it actually maintains the gradient of the osmolality between different parts of this system. That's why it's a counter-transport system. So basically, it operates in a way that it constantly maintains the gradient of osmolality between primal urine that goes from the Bowman space to descending limb and the intercellular space, and it provides like the constant water reabsorption in this descending limb and the constant diffusion of nutrients in the ascending limb. Finally, we have the collecting duct, where there are basically a few phenomena can take place here. like as I mentioned earlier, there are two basically possibilities what can happen with a human. He can drink too much water, for instance, so the human kidney will try to remove the extra fluid from the organism, or there is a dehydration process. That means that the kidney is supposed to return this water from the collecting duct back to the human organism, if that's the case. So basically, this collecting tube has the aquaporin 2, the protein that provides the diffusion of water molecules through the membrane. But when we have we're not dehydrated and we drink a lot of water, this aquaporin is actually hidden within the membrane of the collecting duct. And
what the number indicates inside 300, 400, that's the number, the pressure
that's osmolality. Let me just describe the unit behind this. So it's basically like a molar concentration. If we have the concentration of some solid, we can describe it as usually in terms of this medical stuff, we describe it as millimole per liter. And if it's osmolality, we describe it is basically milliosm per liter. It's basically the same unit as this, but it relates to osmolality. So it's basically the amount of the concentration of substrates diluted per unit of solute. Okay. Yeah, they basically have to get this parameter. So this is the osmolality of the fluid here and here. So this parameter goes both to this. This unit goes both for the urine part and interstitial fluid. All right. I think I was talking about the way how collecting tube duct actually participates in. So yeah, we can expect that if there is a dehydration, then the vasopressin is being generated by human organism. This protein goes to the surface of the membrane of the collecting duct, and water starts to go back to the interstitial fluid. So let me just describe it really quick. Here we are. So I will just draw the collecting duct. So let it be like this. So in normal case, when we consume a lot of water, the kidney will try to remove the excessive water from human organism. So in normal case, usually when this urine returns from the ascending limb, the osmolality of the final urine will be relatively small in comparison with blood. But it actually goes only to the case when we have enough of water and kidney tries to remove extra water to make sure that it will not accumulate in any tissues of our organism, thus harming us. If there is dehydration, for instance, like we do not drink enough water, then the kidney tries to preserve as much water as possible. So when vasopressin is generated by human organism, the protein aquaporin 2 is affected by vasopressin, and the collecting tube is affected by vasopressin. So the aquaporin 2 starts to return water back to kidney fluid. So in that regard, I will just write it like this. Since aquaporin returns back water and the overall volume of the solution decreases and the amount of substrates dissolved in this water remains pretty much the same, we can expect that the osmolarity will go high. That means that collecting tubule will concentrate the urine. And at the end of this collecting tube, the vasopressin can affect the permeability of the membrane of the collecting tube, so it will return urea back to intercellular fluid, thus increasing and maintaining the high osmolarity of the intercellular space. So basically, urea will work here as one of the substrates that will participate in the counter-transport process. All right. Yeah, there are some reference numbers that are related to the way how kidney filters particular substrates per 24 hours. So as you can see, not every substrate is fully removed from the human organism, because we can expect that human organism will require glucose to maintain properly. That means that kidney should function in the way that the huge amount of this glucose should go back to human organism. So that's one of the main purposes of basically nephron as the structural unit of kidney, to return essential units back to organism. That includes bicarbonate, glucose, at some point sodium. So a small amount of sodium is actually filtered out of the human organism. That actually, the reason behind that is that if we have excessive amount of sodium in the organism, it will affect our cardiovascular system. And if there is lack of this sodium, again, it's not very healthy for our human organism. So on one way, kidney should remain a constant concentration of sodium, but because we actually consume with food some extra sodium, the kidney functions in the way that it removes a small amount of sodium to make sure that the concentration of this particular ion will not go too high. So, very
just as you were mentioning, like, it's very interesting that in Indian food, basically we take a lot of additional salt. We are in that habit actually. Many of us like even have the habit of taking salt, additional salt in addition to the curry. So in that regard, like how does the body actually react to that?
Well, those are just reference numbers, so yeah, we have to consider that different cultures have different customs and different cuisine. We can expect that the human kidney will try to extract, to remove as much sodium as possible to make sure that the concentration of this ion will not go way too high. So due to homeostasis, we can just drink excessive water. Some people drink a lot of water, and if in terms of healthy human kidneys, they actually maintain the proper filtration of excessive fluid. And I think the same goes for the sodium. So I'm not a nutritionist, so I will not give a proper comment in that regard, but I assume that kidneys will maintain the same sodium level one way or another, even if the cuisine actually proposes extra salt here. So I don't think that people will eat too much salt in a way or another. So it's like pretty normal that people use the salt as the way to make cuisine more delicious. And but at the same time, humans have like a natural predisposition to avoid eat salt on its own. So yeah, extra salty food, I think that a healthy kidney can manage the extra sodium in blood, but again, I'm not a nutritionist, so I will not be able to provide a specific comment here. Yeah, and basically the same goes for water and chlorine and potassium. So some part of chlorine ions and potassium is also extracted from human body. You can actually see that a huge chunk of the water is actually reabsorbed back to human organisms, so reabsorption percentage is quite high. We still have a small amount of water that goes away from human organism for the same purpose. Kidney is the homeostasis organ, actually maintains the dynamic dynamic stability of the water volume in the human organism. So on the one way, we cannot filter out water from blood in a huge amount, but at the same time, if we drink extra water, we cannot allow the accumulation of water in human organism, because both cases are quite dangerous for human organism. And you can also mention that urea is partially reabsorbed by human kidneys as well. That basically can relate to the factor that urea as a small sized molecule can participate as the osmotic agent within the kidney that allows to perform the transport that we mentioned earlier. So it's not just sodium that participates in this process, but some part of urea participates in this process as well. And if we talk about other uremic toxins like creatinine, that's a byproduct of working of our muscles, the reabsorption percent is 0. So some uremic metabolites are excreted from the human organism completely, although some small amount, some small concentration creatinine is still present in human blood due to the fact that we constantly move and we constantly, our muscles are constantly working. So a minuscule concentration of creatinine will still be represented in human blood. So what happens when the kidneys stop working properly? Basically, we can expect that if kidneys do not function anymore, that means that there is no extraction of the removal of extra fluid from human organism anymore. All uremic toxins that are generated without human organism, they stay in there. And there is actually a possibility that during the chronic, not possibility, but actually a danger that it will stop the homeostasis process at all, because without human kidneys there is no way to properly filter blood. That means all toxins remain in the human organism, all excessive water will start accumulating in a human organism, etc. Unfortunately, it's very hard to predict the development of kidney failure, and especially when we talk about the chronic kidney failure disease, because it's a disease, like any chronic disease, it develops very slowly. And it starts with very insignificant changes in some parameters that are very hard to spot or very hard to identify as the main issue that there might be a development of chronic kidney disease. So one of the primal methods to identify the chronic kidney disease is to measure the glomerular filtration rate. That means that how much water and how much toxins the kidney is supposed to extract from the human organism. And glomerular filtration rate can be described as the relationship between concentration of some substrate in a human urine to the concentration of that substrate in a human blood multiplied by the amount, the volume of urine that is generated per 24 hours or some period of time, divided by the time when we actually measure those units. That's one of the simplified ways to actually measure this particular parameter. But there are more complicated equations that provide a more accurate estimation of this particular parameter, but that one of the easiest way to measure these parameters. So basically, it's the this parameter actually describes how many liters of blood we filter from a specific metabolite. So basically, there should be some reference substrate that provides us the good idea that what glomerular filtration rate is. And usually, as the reference substrate, doctors prefer to use urea or creatinine because they are usually easier to measure and easy to operate in case of the calculation. So in that regard, we can assume that the decrease of the glomerular filtration rate will be a symptom of the developing chronic kidney disease. And there are several stages that actually described by this parameter. So a healthy human kidney actually has a glomerular filtration rate somewhat about 120 milliliters per minute, and this parameter can actually fluctuate during the time because it depends on many parameters like the operation of the heart pumping. It can depend on the how protein-rich the diet of the human of a particular patient. For instance, we still have a parameter of oncotic pressure that depends on the concentration of the protein. And if there is a very protein-rich food, that means that we can expect that there can be a slight decrease of glomerular filtration rate if we calculate it that way. And the main complication of that parameter is that on early stages it's very hard to determine that it is the decrease of the glomerular filtration rate is actually related to the development of the chronic kidney disease. And another issue here is when doctors actually manage to diagnose this particular disease, it's usually too late to make this process reversible, because at early stages there are still methods that provide to regenerate a human kidney, but due to the complexity of this organ and due to low regenerative abilities of that kidney, at some stages this process becomes irreversible. So at the late stages like stage 4 and stage 5, a patient will actually require a renal replacement therapy that we'll address in the next lecture. And due to the complexity to actually determine the development of kidney failure by glomerular filtration rate, there are other symptoms to consider. They actually provide a better outlook of what exactly happens to the human organism. So it's not just we should use glomerular filtration rate as the only method to determine if there is any issue with kidneys, but there should be the rapid increase in blood urea, increase in metabolic acidosis, because kidney actually provides the homeostasis of pH of blood, and if there is a acidosis one way or another, that can be a potential symptom of the chronic kidney disease. It could be the change of the potassium, iron concentration in human blood, etc., and so on. So basically, it's a very complex problem on itself on how exactly we should diagnose this chronic kidney disease and how we make sure that these specific symptoms lead us to development of chronic kidney failure. Because again, it's essential to actually diagnose this particular disease at early stages when it's reversible, because when the doctor actually misses the opportunity to diagnose it earlier, we can actually go to the stages when this process becomes irreversible and the residual kidney functions will steadily drop until the kidney will not filter blood at all. So it's a terminal chronic kidney disease stage, which actually requires a kidney transplant or a constant renal replacement therapy. Yeah, there is a short overlook of the kidney disease burden. So right now, there are about 830 million people with different stages of chronic kidney disease or any other kidney diseases, and there are more than, as far as I know, 30 million people who suffer from different stages of the stages of kidney disease that require renal replacement therapy. And basically, this burden leads to the increase of the mortality rate because of this particular disease in many countries like Israel, for instance, or countries of Mesoamerica, etc. It becomes one of the main causes of death if we talk about the chronic organ failures like heart failure, liver failure, etc. Of course, the heart failure is the main cause of death if there is no way to help a person with the heart failure. There is a bigger chance he will die of heart failure than the kidney failure, but nevertheless, kidney failure is a huge burden for the global healthcare system, because the amount of people who actually require renal replacement therapy grows every year, and that creates a certain pressure on the healthcare system to develop opportunities to provide renal replacement therapy for people who suffer from that disease. Oops. Yeah, this is basically a trend of increasing death rate from the 2013, and in 2040, on global scale, it will become the 5th cause of death among the organ failures. Right now, if we talk about the current stage, it's about the 12th main cause of death. So basically, despite the fact that it's not like one of top 10 causes of death, it's still a very prominent disease that leads to a very high death rate from this particular disease. Yeah, that's a quick overlook on the artificial kidney development. So if we talk about how exactly we help people with chronic kidney disease, of course, the most logical solution in that regard is to perform the organ transplantation, because, as we know, kidney is the organ is a very sophisticated organ that performs a lot of functions, and it is very hard to actually replace all endocrine function, reabsorption function, etc. by means of the simple blood filtration. So the most logical solution will be the organ transplantation as the golden standard of the renal replacement therapy. Unfortunately, as we actually mentioned that in the second lecture, we cannot provide all patients with terminal kidney failure and chronic kidney failure with organ transplantation. That means that people will still require renal replacement therapy in forms of hemodialysis, peritoneal dialysis, etc. And there is like a short historical background between development of the artificial kidney. The first available renal hemodialysis system was actually developed in 1943. In 1945, it became available in manufacturing, and this device was developed by William Koch. The other landmarks actually provide the other landmarks about the development of organ transplantation that became the golden standard of okay. Yeah, I will quickly, thank you for your attention. If you have any questions, you're...
The first picture is open or going on? First session? First session is going on?
I think we can start Q&A section. And we can address this particular topic in future lectures. I'm sorry that I exceeded the time of the first lecture.
So actually you have to change the YouTube link.
Okay.
So So we can change it now. It will be
All right.
second lecture will start.
Yeah.
This is in second lecture.
No, the second lecture will go on as a file.
As of now. So
Yeah.
this is the last one. The first lecture.
Yeah, that's the last slide. I will address it in the future lections. Yeah,
Yes.
yeah, if you have any questions, we will just discuss the matter of the future perspectives of the renal replacement therapy development. And basically the main summary of that lecture, if we want to develop the implantable kidney, basically the device that has to imitate the work of the native nephron, we have to, at very least, have a general understanding of how blood filtration and substrate and water reabsorption happens in human blood, because this is what we have to imitate an
Multiple
implantable
Indian
kidney.
companies use the name
Yeah,
Rush Corporations.
If you, yeah.
So as you have mentioned that the chronic kidney disease, if it is detected in early stages, it can be reversed.
Yeah.
So what are the parameters that can be measured or tested to detect it early? See,
Yeah, speaking of early detection, I think the one of the methods that can be used is the measuring of glomerular filtration rate when we measure a specific marker in human blood and in human urine, and we actually estimate what kind of urine is produced by human kidney, and using the references number rate that gives us the general idea that at this point the glomerular filtration rate will be at some stage of it will be rather healthy for reference for a healthy kidney, or there is some complication with that. But for doctors, the main issue is to actually evaluate if this glomerular filtration rate is related to the chronic kidney disease development.
Like those parameters they measure GFR. I think whether or not they recommend this test or not, but they mostly measure creatinine, urea, and other parameters.
Yeah, the urea is the easy marker to actually estimate the kidney function. You, for instance, can estimate you can basically estimate if there is some complication with the human kidneys in terms of there is a drastic increase of urea or any nitrogen-bound toxins in the human blood, and they actually prescribe you to not to eat anything before the test, because any food consumption will lead to eventual increase of the urea concentration, which is basically a very natural process, especially when it goes to protein-rich food. And yeah, as I said, I'm not a nephrologist, of course, so they measure a lot of parameters, and glomerular filtration rate is just one of the parameters they control. Of course, they have to control what's the actual urea concentration in human blood, what is the concentration of creatinine, uric acid, and other parameters, how the iron concentration was affected, if sodium level is high, etc. So it's a complex issue that requires a lot of steps to actually estimate if there is a chronic kidney disease, or it's acute kidney disease, or any complication with the functioning of the human organ. Yeah.
so why the stone, sir? This kidney stone in India is very big problem.
Yeah.
Kidney stone.
Yeah.
So what is the main reason behind the kidney stone? Means how the stone will be made in kidney?
Well,
Kidney stone is a major problem, sir, in India.
Yeah.
Most of the people after I have seen after age approximately 30, 40 mostly, but in some child also means in general I have seen so many people survive this kidney stone problem. So why the stone, or how the stone means inside, how will made the stone, means how the is.
I'm not like a nephrologist who can explain in full how exactly it happened. I would just assume that it could be related to the formation of such substrates like uric acid and the acidosis that can happen inside of human kidney, which will lead to the problem that some substrates do not dissolve properly anymore. And if they do not dissolve, they just start accumulating in a solid state, and this will lead to the formation of the crystals or stones that accumulate in the collecting ducts or the urethra, etc. But again, it's not my main field of expertise. Basically, it can be related to the diet or the personal human conditions if they can deal with a lot of uric acid or not. But again, yeah, that's the matter.
Diet is another. The less water consumption.
Okay.
That is the very much main problem in Indians. We do not used to take a lot of water actually. Due to the less water, the urea concentration becomes solid, and it makes a crystal type of thing. So that is the major concern cause of the stone. Yeah.
Okay, sir. Got it, sir.
Yeah, thank you.
Thank you, sir.
Yeah.
Thank you for the lecture.
Yeah.
So as I understand that sodium is one of the, let's say, one of the players in this in the functioning of the kidney.
Mm-hmm.
I wanted to ask, because there are some people who have hyponatremia or a natural lack of sodium in their bodies. So I wanted to ask, does the kidney of such a person operate differently from a normal person's, or is there any difficulty in sort of simulating their kidney?
Yeah, I will assume that there could be some differences in the way how kidney operate during the pathologies that people can develop, or they can have inborn pathology that does not allow them to have a healthy concentration of sodium. Unfortunately, I'm not a doctor to explain that at full, but yeah, we can consider that there can be conditions of human kidneys and human organism as a whole, which can lead to the difference of the sodium level for different people with different conditions.
My question was, will the kidney of such a person with hyponatremia, will that be essentially different from, let's say, a normal healthy kidney?
Well, I don't think that I'm qualified enough to actually respond to that question at full. Like, the main idea of that lecture was to actually provide the idea that there should be some understanding of technical level how exactly the blood is filtered here. Of course, in order to work on that subject, we need to introduce nephrologists in that field, because without nephrologists, of course, an engineer will not understand the full capacity of a human kidney. But at the same time, engineer has to acquire some very basic level of how human kidney operates, because this is what he needs to imitate. And my lecture was about the idea that to introduce this topic, that if engineer wants to work on the field of implantable kidney, he will have